Hello, my name is Nurse Engee. This topic is hypoparathyroidism, protecting the body's balance. Let's look at the pathophysiology. Deep within the neck lies a small but powerful system, often overlooked yet essential for life. The parathyroid glands. They are four tiny structures located behind the thyroid, a butterfly-shaped gland, which plays a critical role in maintaining calcium balance in the body. Hypoparathyroidism is an endocrine disorder characterized by insufficient secretion of parathyroid hormones known as PTH, resulting in hypocalcemia, low serum calcium, and hyperphosphatemia, high phosphate levels. The parathyroid glands produce parathyroid hormones known as PTH. This hormone regulates calcium levels by acting on the bones, kidneys, and intestines. When PTH is released, calcium levels rise. When PTH decreases, calcium levels fall. This delicate balance is essential for proper muscle contraction, nerve function, and cardiac activity. In hypoparathyroidism, there is a deficiency of PTH, most commonly due to autoimmune destruction, genetic disorder, accidental damage, injury, or removal during a neck or thyroid surgery called thyroidectomy. As a result, calcium levels drops, leading to a condition known as hypocalcemia. Now, when you think about hypoparathyroidism, you need to think about hypocalcemia because hypocalcemia is what's going to cause these symptoms and manifestations. Let's look at the clinical features. Clients will have a decreased calcium levels, but an increased phosphorus levels. Remember that calcium and phosphorus have an inverse relationship. So decreased calcium causes inverse phosphorus levels, and we are going to have the decrease in the PTH. The effects of low calcium can be widespread and dangerous. Clients often experience tingling and numbness in the hands, feet, and face. Muscle contraction becomes abnormal, leading to painful cramps and spasms. There are two classical clinical signs which may appear. A carpal spasm when a blood pressure cuff is inflated, known as Trousseau's sign. And facial twitching when the face nerve is tapped, known as Chvostek's sign. But the impact doesn't stop there. The heart, a muscle itself, becomes affected. Electrical conduction slows down and stretches out, leading to a prolonged QT intervals on the ECG. In severe cases, clients may develop tetany, intense, sustained muscle contractions. Even the airway muscles can spasm, causing difficulty swallowing, which is known as dysphagia. Laryngeal spasm or difficulty breathing. Most critically, hypocalcemia increases central nervous system excitability, placing patients at high risk for seizures. Let's look at the nursing interventions. Nursing care plays a vital role in preventing complications and ensuring client safety. Because of seizure risks, seizure precautions must be implemented. This includes padding the side rails, loosening clients' clothing, keeping functional suction equipment nearby, and ensuring a safe environment. Continuous cardiac monitoring is essential to detect dysrhythmias caused by prolonged QT intervals. Diet is also very important for clients with hypocalcemia, especially when it's mild. We want to encourage a diet that is high in calcium and high in vitamin D because vitamin D is going to enhance absorption of calcium. Things like dark green vegetables and tofu are great options for these clients. It's also very important that clients maintain a low phosphorus diet because if we have a high phosphorus diet, we are going to counteract the increase in the calcium intake. As a rule of thumb, clients should replace animal proteins with plant proteins. We need to make sure they're still getting proteins, but a lot of animal proteins, especially meat, are going to have high phosphorus levels. High phosphorus levels can further decrease calcium, worsening the condition. In mild cases, oral calcium and vitamin D supplements such as calcitriol are prescribed. In severe hypocalcemia, immediate treatment is required. Intravenous calcium gluconate is administered, preferably through a central line to reduce complications. Remember that a normal serum calcium level is going to be 9 to 10 milligrams per deciliter or 2.25 to 2.26 millimoles per liter. So for clients experiencing mild hypocalcemia, which is a calcium greater than 7.5 milligrams per deciliter or 1.9 millimoles per liter, we need to encourage oral calcium and vitamin D intakes such as calcitriol. Now, if clients are experiencing severe hypocalcemia, which will be a calcium less than 7.5 milligrams per deciliter or 1.9 millimoles per liter, we need to administer IV calcium gluconate. If possible, calcium gluconate needs to be given through a central line to reduce the risk of extravasation. This ends the topic. See you next time.